Okay, let me know if you can see my screen.
We can see it, Chris, if you want to put it in the presentation mode.
Yeah.
That's great.
Okay, I'm just gonna sort of jump into it. This is, what we've done is we've thought a lot about consumer healthcare over the last 7 years, and we're always working to distill the message down. Why we're doing this, why we're here. Are we here just to allow a provider to, you know, uh, get their visits done and meet the requirements, or are we trying to do something different? And one of the things we believe, a number of us who have worked in value-based care organizations, been responsible for risk and quality, is that um, providers are really outnumbered by the amount of programs that they have to attest to, whether it be quality or, each organization has just a ton of things that, really outnumber the ability to do them all successfully. And so what most organizations do is they pick and choose which ones are going to be make the most impact and for both mission and for margin. And when you think about that problem, you ask yourself, well, what can we do to make this easier on the providers? And one thing that is talked a lot about in different organizations is putting the patient first. But when I look at what are we doing to make it easier for the patient to be in the center, I don't see a lot of things. And so one of our real hypothesis is that we can make huge investments all over the industry, all over the system, but if we're not doing anything to make it easier for that patient to understand their disease state. And I'm mostly talking about the patients with one or more chronic conditions, right? Not the healthy 30-year-old that has a just some minor acute issue. I'm talking about the people who are really in need of additional care and support, the ones that are costing the dollars in the system. And our belief is that they have to have two things. And without those two things, there really is probably no way we're really going to sustainably change healthcare. And patients need to be able to understand their disease. They need to be able to know what symptoms should I look for, because the system right now puts that burden of risk on the patient. The model is still the same. You come to me, the provider, when you have an issue. You decide when it's too bad. What we want to do is make it easier for that patient to understand what those symptoms should be, and at what point does it make sense. The challenge, though, is the system itself makes it difficult. It raises the barrier for, I've got this new or worsening symptom. It's not that bad. I'm just going to wait it out. Well, by the time you wait it out, it gets pretty severe, and it's usually too late to deal with it in an acute setting. And so we all know what happens. So we have to have the literacy component, but we also have to make it easy and convenient for patients to be able to submit these symptoms to care teams, not necessarily a provider, but someone on the care team, so that we take away the real and perceived barrier of making a phone call, waiting on hold, relaying your message to somebody, waiting for a call back, playing phone tag. All of those things are things that enter into the patient's mind to say, I'm not ready for that yet. I'm going to wait this out a little bit longer. So in a nutshell, that's our premise. That's what we were trying to solve. And so this is just basically another slide that gets down to the details of that. What's also important here is that it's with your PCP, the PCP who has that longitudinal relationship. Literacy, access, and the longitudinal relationship, we believe, are key to making healthcare better and cheaper. And you're all just jump in whenever you have a question or a comment. And this is essentially what CareConvene is. It's really three things. It is the telehealth application. It's the secure HIPAA compliant chat and video. It's what's unique about it, though, is it's something where the patient can initiate it as well as the practice. What we're seeing in Michigan and across the country is most virtual visits are done with a provider pushing out a link, pushing out a Doxy.me, pushing out a secure Zoom, and that's all it is. And that's good. That's an important step, and that step help clinicians realize that they can do quality care digitally. And so that was a good first step, but we need to take it further. We need to make it possible for patients to initiate those things. And there are a few systems around that are, offering those types of tools. But the vast majority aren't, right? And I think that's really where the virtual health needs to go, is patient initiated, patient reporting their symptoms, et cetera. So that's one piece of the CareConvene strategy. The second piece of what we're doing here is really, and it's been a wonderful relationship with MiHIN, is that's the delivery of ADTs. If we think about the virtual visits, the patient initiating it, the patient submitting their symptoms, that's what we really call the first mile of care. That's largely been ignored by the industry. Getting ADTs, getting those discharge notifications, those admissions, helps with that last mile of care, helps those clinicians identify when and where those patients are going or coming from, allows them to jump in, get that ADT real time to their phone, make a phone call to the patient, and start a virtual visit without the patient having an app or a registration in the system. It's a quick one-time link, very similar to a Doxy.me or something else. And so that's what we call the last mile of care. But straddling and supporting both of those things is our consumer access. Again, we believe that if the patient isn't literate, doesn't have the means with which to understand their medical information, their symptoms, their allergies, their medications, we're not going to get as far as we could. And so we have something called a personal health record. And this year, many of you may know that the CMS is now set a date as July 1. They'll start penalizing payers if they don't have API access to third-party apps. And what CareConvene has found is there's a lot of opportunity to pull this consumer information into an app. And so that's really the third leg of what CareConvene is doing. And it really supports everything, because what it does is, if I'm able to pull all my information down, that's a history of information that my provider may or may not have. And so when I'm doing a virtual visit with my provider, that patient can consent to allow that provider to see all of that information during the visit. And I can show you an example of that. So those are really the three main things that we believe are important to care: literacy, first mile, last mile of care. And you'll see this, right? This is a visual representation of what happens. If we can't control symptoms early on, they're going to go here. And it's an interesting place where high convenience and low cost intersect. It's usually the opposite: high cost for convenience, and this is the opposite. And so, again, the awareness, the access, and the relationship is key, in our belief, to making better healthcare. This is always in flux. This is just a maturity model. It's kind of how we here at MiHIN think about consumer health and where we think it's going. I won't spend too much time on this, other than I think we're still here in this reactive state. Most of us, we are pushing visits out, but there's a whole lot more we can be doing. And we can be building better relationships between patients and providers, so patients can go to their provider. We can be pulling in remote patient monitoring data, integrating with HIEs to allow providers more information. And I think where it's all going to go is consumers are going to have a vast amount of information. They're going to have tools at their fingertips. They're going to have all kinds of providers at their fingertips to help them. And so I always try and say, if you're an independent physician or even a health system, the best thing you can do is be that easy button for your patient, because they're going to find it somewhere, sometime. A lot of this whole hypothesis that we've had has led us into some really interesting opportunities. And I think this is the meat of what I think Drew and team wanted me to sort of talk about, because there's lots of opportunity out there. I threw this quote in here because I think it's key. It underscores everything we do. And you may know Dr. Van Wingen. He's a family medicine specialist at Grand Rapids, and he always talks like this, and he just says that communication done right is the root of almost every positive experience in medicine. Conversely, communication done wrong is at the root of most every negative experience. And think about that in your life. Either the lack of communication, which is a bad experience, or a lot of communication that's not very helpful, and how bad that is. And your ability to communicate with your provider or their care team is incredibly important. So we think that underscores just about everything we do. And so the list here, these are some of the projects we're doing. The integration with CareConvene and MiHIN in late 2018 into 2019, caught the eye of a few payers, and we were asked to do a project to reduce readmissions. And the idea there is, how do we reduce readmissions? Well, if we go back and ask why do readmissions happen, it's because there's probably poor communication between patient and PCP. Well, how do we make sure that the PCP knows that there's a discharge? We give them an ADT. How do we make it easy so the clinical team can then in real time interact with that patient? We deliver it through an app-based experience so that they can call that patient, see where they just got discharged from, start a virtual visit. And so that is what started a lot of work around combining consumer health and health information exchange together. And as you can see here, a number of projects have followed. That second bullet there, ER clinical coordination to avoid unnecessary inpatient admissions. There's many times patients will go into the emergency room either because their practice is closed, they can't get a visit, or for who knows why. They show up in the emergency room and they're there. And so the provider really doesn't have the clinical relationship like the PCP. If the PCP could just get an early warning and the care team could call that ER and say, hey, I noticed Chris Bailey's in your ER. What's he in for? I think I can handle that. I'll schedule him an appointment today or tomorrow. We'll take care of it. There's no need to admit him. Think about that coordination and communication, very powerful. Second bullet, we're just doing some unique things with self-funded, recognizing that employers who are moving to a self-funded space want to test new care delivery models and have a little more flexibility in the self-funded space. So we're doing a project there where we're sending ADTs back to Michigan for Blue Cross because they have hosted members who are working in facilities that are owned by Michigan-based companies. Especially team-based care. That program, in essence, really came out of the first project we did, that top one, the reduction in readmissions project. And now we're starting a number of remote patient monitoring projects, and then patient campaigns. And so again, at the most fundamental level, what we're trying to do is make communication easy between the provider and the patient. And I think that's it. That's it from the slides. I can show you a few things, Drew. I'm not sure how much time I have slotted, but I can get in and show you a few things and why we think it's important.
Yeah, I'm curious, Chris, you can certainly queue that up. I'm wondering from the group, any reactions to the pilot and those sort of applications of the telehealth solutions we have here in the state of Michigan? Any questions on those or discussion points on things that may be relevant to your organizations or questions about this?
Yeah, while folks are thinking or maybe coming off mute, just interrupt me. But the patient campaigns I'm particularly excited about. This isn't completely built. We have all the components. We are just wiring things together now, and I'll show you how we use assessments, how we use this text to visit feature to get a visit started without the patient needing to be registered in CareConvene or without the app. How we use attribution groups, scheduling, et cetera. But what's exciting about this, and we'd love to find more organizations, physician organizations to partner with, is if we can, one of the projects is around, colorectal screening. Thousands of patients who are due who have a gap in care. You can send them a letter, they'll read it. but there's a real or perceived barrier to responding. You have to go in, you have to make a phone call, which we all know what that is like these days, because our expectations have been set where you can just send a text. That's the new ideal of communication. Send one text and be done. So anytime you have to make a phone call into a black hole, you're not really sure what you're going to get, how long it's going to take. There's a real and perceived barrier. So I think the response rates are usually pretty low on those things. And same for the phone call. You get a phone call you don't recognize, you're in the middle of something, what do you do with it? You don't answer it. But if you were to get a text or an email that gave you a link that allowed you to fill out an assessment, answer a few questions, schedule your pre-screening visit, so you could get a link down the road, just open it up and have that screening. That is a whole lot easier because it's this idea of passive waiting. I can take my packet of information, send it, and wait for the other party to do their part, and I can go back to doing whatever I was doing. I think that's the key to creating convenience. And so we have a lot of hope that this is, we do this for one or two, just think of all the different HEDIS measures we could start activating, nudging, and creating some level of engagement with patients. So anyone want to jump off and ask questions? Throw some comments in. You maybe tell us what you're working on. I'd be equally interested in hearing you talk than me talk. More interested. And Drew, if you want me to
Chris, maybe
pivot into
if you want to share, just a few more of those functionalities that you want to share, that'd be great.
Okay, yeah, I'll jump in here and let me pull up my browser here. So, just quick high level, not sales pitch, but just kind of some of the functionality that we are doing is we have a couple different ways patients and providers can interact. We certainly have the text to visit. This is the feature that most all of you will be familiar with. It's a way with which you can send a link out to a patient so that patient can click a link and turn the video camera on. Great little feature, easy, lightweight, doesn't require hardly anything on the patient side. All they have to do is get a text or an email. So that is an important tool in the toolbox. The other thing that, and I'm going to share my screen here. Apologies if it's not perfectly fast. There we go. Okay, so hopefully you can see my screen here. I'm going to make this a little smaller. So CareConvene also has a provider app. So a clinical team member who wants to receive ADTs, wants to push it, start a virtual visit, wants to be able to receive a virtual visit, they can do all of that in the browser here or from an app. We also have a patient app, and I'm just showing you my beta app right now. And so what you're seeing here in the patient app is a couple different things: our home screen, our visit. So the way this works is any practice can brand themselves in the CareConvene platform so that they give a patient a code and they are automatically linked to that practice. They could have their primary care practice in here, their dermatologist, and in theory, their behavioral health specialist. And the reason we think this is advantageous is it's one place. I don't have to be in 3 different EHRs. And so that's I think interesting to me as a patient. I can have one-stop shop. What this does is allows the patient to start a visit either for their themselves or maybe a dependent. I can pick any doctor that's in the practice that's available, or some are by appointment only. So I'm going to pick Dr. Cooper. And if you saw, I could schedule a visit with him. I can have whatever reasons for visits I want. That's totally customizable. And I can then charge whatever I want, add photos, and I can create, I can have these assessments assigned to each of the visits, and I can start a visit this way. And the idea here is that the way this works is in many applications that I've seen, when the patient starts the visit, they're actually starting the video. Our video isn't the visit. We have a visit, and then within the visit, there's chat, there's video, there's photo upload, there's all those different things. And so right now what happens is the provider care team gets a visit, and they can have anyone in the practice go in here and look at what the patient attested to, and they're filled out their assessment. And you could have the front desk person asking for an insurance card and a driver's license. They can jump out. The MA can come in and do their virtual rooming questions. The RN can ask a few questions. And then if you need the provider to come in at the last minute, they can do the same thing. And so the idea here is we start the visit. And I click OK. And now I'm in, and I can do chat messaging, secure chat, or I can turn the video on. And I can turn that video on as many times to keep it on for as long as I want. And so that's the idea there. Remember I said that if the patient downloads any information from a payer, like Blue Cross or whatnot, app, whatnot, that information is stored in here so that the provider and the care team can see that information. Remote patient monitoring data for whatever we may be hooked up to in the future, that information will be here. So we're trying to make it a full experience for the patient and then be able to share that information. So I'm just going to end this visit here and just show you two other things real quick. There's many times we will go in and, a organization may not need telehealth because by this point, everybody has some. Either they're trying to figure out, does it meet their needs, or
there's going to be a day that might.
And looking for something else. The other thing is, let me show you the assessments. These are the assessments here. So this patient has CHF. So I've assigned her the CHF assessment. The way this works is this is teaching that patient what to look for. And everything is set to a positive sentiment, no issues. As soon as I click on a worsening symptom and I click save, that immediately is sent to the patient notifications. This is where symptom reporting for, high risk patients with chronic conditions, maybe patients who, just got discharged from the hospital are still not back in homeostasis, maybe a population of patients who get knee surgery, hip surgery, general surgery, give them something that they can help to understand their disease and give them a way to report what's going on and make it easier. So that person who had a sponge left in them and is not feeling good on day 2 can report that and say something's not right. And in real time, we can go and investigate it before it gets worse and before the unthinkable happens. That's the power of just providing simple communication between groups. And so in this scenario, the provider has a way to respond. They can turn this on and start a visit right from here. And so you'll see right here, now in real time, I, as the patient, got a response. I can turn that assessment, that report of assessment, into a virtual visit. And so you saw me push a visit out through the text to visit. You saw me initiate a visit through the visit tab. You also saw me use these assessments to connect to a provider care team and get a visit started through there. And so those are essentially the 3 ways with which we do that. Real quick, for those who are interested in some of the other tools, the consumer access, we have data providers here where we have a number of plans that are in here so that when that information is downloaded, it goes into the personal health record. And that's going to be the foundation for patient understanding their symptoms and having that conversation with their care team in the future. One last thing I'll show you is the ADTs. So we'll also have an ADT delivery system. You can sort on many different things, ADT classes. We've got a couple extra special programs. We've got disposition codes, so you can really filter on whatever you want. We do allow you to, throw in, to have the CCD. And then we also have this little feature here, which is the ADT comes in, we see the patient's phone number, we can call the patient. We can do that 48-hour transition of care call so that we can qualify for the 7-day visit. And those visits can be done virtually. And so what you'll see here from my screen is I'll just choose any doctor. I get a text now. So I take an ADT and actually turn it into a visit interaction. And so all I have to do is, turn the stuff on. So in essence, that's the meat and potatoes of it. That's what we're working on. Happy to entertain any questions. Would love to know too if any of the folks on the call are doing anything like this in their organization. And if you are, I'd love to, compare notes and share our lessons learned, and if you're interested in doing the same.
Well, Chris, I want to thank you. This is Drew from MiHIN. Thank you for that presentation on CareConvene, also reviewing some of those pilot opportunities that we pursued during the pandemic. So, Chris, thanks for that presentation. Really appreciate it.
Yeah, my pleasure. And if anyone's just close to this final thought, if you've had a hypothesis on how you can improve care delivery, and you think there's a place, a way you can reach patients better and deliver that care better, I would be happy to help you make a proposal. That's what I'm passionate about. That's what I'm trying to do. And there's lots of opportunity out there still. So, and there's probably dollars out there to get it started. So, send me an email. It's just chris.bailey@mihin.org. So happy to work with you in the future in any capacity. Thanks, Drew.
Thanks, Chris, for that. I did just put my email address in the chat. If there are questions after we end here in a minute, please feel free to email myself, drew.murray@mihin.org. With that, that's the end of our agenda for today. Thanks, everyone, for joining again in the summer. Our next meeting will be right after Labor Day, September 7th. It's always the first Tuesday of every month, so September 7th at 11 o'clock. And until then, we hope everyone has a good rest of your summer. Thanks and bye.